Nursing 5303, Advanced Health Assessment. This is a presentation on a head-to-toe assessment by Christine Miller. My name is Christine Miller, and today I'm going to be performing a head-to-toe assessment on our patient, volunteer Bonnie Post. Before doing the head-to-toe assessment, I would do a complete history with the patient. I would also take a full set of vital signs. During the head-to-toe assessment, I'm going to be observing things like the patient's speech, her hearing, how well she's able to hear me, and I'm going to be observing her skin the whole time. So the start of the head-to-toe assessment, we're going to start with her head and just look for any lesions, anything going on with her scalp. From there, I'm going to palpate. Do you have any pain?
No.
I'm also going to be looking at her face for symmetry. Can I have you lift your eyebrows for me? Okay, stick out your tongue. Perfect. And then I will be doing an eye exam. I'm going to have you take off your glasses for me. Just going to be looking into your eye, looking for any scratches, any lesions. Her pupils are also equal, round, and reactive to light. Now I'm also going to have you follow the light. This time I'm going to test some cranial nerves and see how her senses are. I'm going to have you close your eyes for me. Tell me if this is soft or hard or sharp.
Soft. Soft. Sharp. Soft. Sharp.
Sorry.
Soft.
And then we're going to be using the tongue depressor. I'm going to have you open your mouth for me and say ah.
Ah.
Her uvula is moving up and her tongue is again symmetrical, which are good signs. We'll look again with the tongue depressor, say ah.
Ah.
And the patient does have a positive gag reflex with that as well. So from there, I'm going to be looking in the patient's ears. First of all, I'm going to be looking for any rashes, any cuts, any lesions, any redness, which I don't see any. The ears are symmetrical as well. Does that hurt at all?
No.
I'm going to be looking into her ears. Perfect. We do not have a tuning fork here, but at this time I would use a tuning fork. I would tap it on my hand and put it in the middle of her head and ask if she can hear the sounds equally in each ear. From there I would tap it, put it behind her mastoid and ask when she stops hearing the sound. I would then move it 2 to 3 centimeters out and ask when she stops hearing the sound that way. I would do the same thing on the other side as well. And then from there, I'm going to palpate her sinuses. Do you have any pain or pressure with that?
No.
I'm also going to be palpating her lymph nodes here. Any pain?
No.
Okay, and from behind, I'm going to palpate the thyroid gland. Any pain?
No.
I'm also feeling for any masses or swelling, which I don't feel. I'm also looking to make sure that the trachea is midline at this time. Now I'm going to be listening to her lungs. Deep breath. One more time. I'll also be listening from her back. Breath. In. important to listen in the different lung fields. You also want to palpate and feel for any crepitus here, which I don't feel. I'm also going to listen for her heart sounds at this time. I'll be listening for the aortic valve in the second intercostal space to the right of the sternum. To the left of the sternum, second intercostal space, the pulmonic, and then the third intercostal space will be Erb's point, and the fourth intercostal will be mitral. You can just breathe normal. Perfect. At this time, I'm going to have you lay back for me. I'm going to palpate her abdomen at this time in the 4 quadrants. I'm also going to percuss, listen for different sounds, and I'll be listening to her vowel sounds as well in the 4 quadrants. And then at this time, I'm going to be doing some muscles as well and asking, can you squeeze my hands for me? The grips are both equal. I'm going to have you close your eyes and put your arms up for me. You have them do that for 10 seconds and look for any swaying, which I don't see. You can relax your arms. Can you push up on my hands? Perfect. And pull down. Perfect. I'm going to be looking at her legs, looking for muscle tone, looking for any skin discoloration. I'll also be looking at her toes and have you press down for me. Pull up. Perfect. I'm also going to be looking for range of motion between each toe. Do you have any pain?
No.
And I'll also be looking for range of motion with her hands. Any pain with that?
No.
Sit back up. So from there, we're also going to do the visual acuity test. So I'll have you put your glasses on. So at 15 feet, I'm going to have her read line 9.
LEFODPCT.
Okay, can I have you cover your left eye?
LEFODPCT.
Okay, can I have you cover your right eye?
LEFOPCT.
Okay, and then I'm going to have you take your glasses off. And this time I'm going to have you read line 6.
EDFCZP.
Perfect. And then I'll have you cover your left eye.
EDFCZP.
Okay, and I'll have you cover your right eye.
EDFCZP.
Perfect. Okay, then next we're going to have you I'm going to have you stand up off the bed and we're going to do some stuff with gait. So I'm going to have you stand on just your right foot. Perfect. And I'm going to have you stand just on your left foot. Perfect. Making sure she has good balance. And I'm just going to have you walk across the room. I'm going to observe for any swaying if she can ambulate well by herself or not, which she can. And then I'm going to have you sit back down. And then I'm going to have you touch my finger to your nose really quickly. Okay, can you do that with your right hand? Perfect. And then on your own fingers, I want you to touch your thumb to each tip of your finger. Perfect. So that's going to conclude our head-to-toe assessment at this time. I thank Bonnie for being our patient. Pediatric eye exam. We now must take consideration for the pediatric eye exam. Infants often shut their eyes tightly when their eyes are being examined. To help with this, have the parent hold the infant over their shoulder and position yourself behind the patient. Turning off the overhead lights may be helpful as well. Be sure to inspect the infant's external eye structure. During this time, pay close attention to small or differently shaped eyes. You also want to inspect for epicanthal folds, which is a vertical fold of skin that covers the lacrimal gland. Observe the alignment and slant of the palpebral fissures. Inspect the level of the eyelid covering the eye. Observe the distance between the eyes, looking for wide spacing. Inspect the sclera, conjunctiva, pupil, and iris of each eye. The newborn's eyelids may be swollen from birth trauma. In children, you will inspect the child's external eye structure as described for the infant. Test visual acuity with the Snellen E-game or other vision charts for children. Examine visual acuity by observing the child's activities. If the child is able to stack, build, or place objects inside others, they usually have no visual difficulties in one eye. Remember to have patience with the child. You can always recruit the parent to help you to have the child sit in their lap so they might cooperate better. Pediatric ear exam. Just like the pediatric eye exam, special considerations are to be taken. Along with the nose, mouth, and throat, the ears are a common site of congenital malformations in the newborn. First, you will examine the auricle, which should be well formed with all landmarks present. It is important to remember that the infant's auricle is very flexible, and a premature infant's auricles may be flat. The tip of the auricle should cross the imaginary line between the inner canthus of the eye and the prominent portion of the occiput, varying no more than 10 degrees from vertical. To perform an examination with the otoscope, place the patient supine or prone so their head can be moved from side to side. The ulnar surface of your hand should rest on the infant's head, so when their head moves, the otoscope moves as well, reducing risk for trauma. You will use your other hand to pull the auricle down to straighten the upward curvature of the auditory canal. Hearing screenings are recommended for all newborns and should be performed at regular intervals for infants and children. Responses to repeated sound stimuli will decrease as the infant tunes out the stimulus. Children often resist otoscope examinations, so it is wise to leave the exam until the end. Positioning the child on the parent's lap during the exam will make the child feel more secure than placing them on the table in a prone or supine position. Different positions may be used to help stabilize the child. To gain the best view of the tympanic membrane, pull the auricle downwards and back or upwards and back. You will observe the response to a whispered voice and various noisemakers to screen the toddler's hearing. Breast examination. During the breast examination, have the patient sit with their arms hanging at each side. Inspect each breast and compare size, symmetry, contour, skin color and texture, venous patterns, and lesions. Be sure to lift the breast with your fingertips to inspect the lower and lateral aspects. Venous networks may be visible, but they are usually pronounced in obese and pregnant women. Venous patterns should be symmetric. You will inspect the areola and nipples in both men and women. The areola should be round or oval and bilaterally symmetrical. Montgomery tubercles may be present, but the surface should otherwise be smooth. Inspect to see if the nipples are everted or inverted, and ask the patient if this is normal for them. The nipples should be homogeneous in color and match the areola. Re-inspect the woman's breasts with them seated with their arms over their head or flexed behind their neck, seated with their hands pressed against their hips with their shoulders rolled forward, and seated and leaning forward from the waist. After inspection, palpate the woman's breasts symmetrically. This can be brief with men, but should still be completed. You want to palpate all breast tissue, feeling for lumps or nodules, remembering that breast tissue extends from the second or third rib to the sixth or seventh ribs, and from the sternal margin to the mid-axillary line. Palpate the breast with the female patient in seated and supine positions. Female genitalia examination. Though most women aren't excited for the pelvic exam, most women do not have anxiety over the exam either. When doing a pelvic examination, be sure to explain everything you are doing. It is important to show the woman the instruments you will use and explain their use if the woman is unfamiliar with them. Remember to always be culturally sensitive during all exams, but especially during the pelvic exam. Have the patient empty their bladder before the exam and make sure the room temperature is comfortable. Assist the patient to sit in the lithotomy position and help them slide their buttocks to the edge of the table with their feet in the stirrups. Drape the patient's knees and depress the drape between the knees, allowing for you to see the patient and for the patient to see you as well. First, you will inspect and palpate the external genitalia, looking for hair distribution and noticing surface characteristics. You will continue to inspect and palpate the labia majora, labia minora, clitoris, urethral orifice, vaginal introitus, the skein and Bartholian glands, the perineum, and the anus. Be sure to inspect muscle tone as well. For the internal inspection, be sure to be familiar with the speculum and have it well lubricated. You will inspect the cervix for color, position, size, surface characteristics, discharge, and size and shape of the os. During the bimanual examination, you will continue to explain to the patient what you are doing. You will locate the cervix, followed by determining the uterus's position, size, shape, and contour. Last, you will palpate the adnexa and ovaries. It is also important to do a retrovaginal examination if the patient allows. If the patient is hesitant, explain to them the importance of the examination. Male genitalia examination. During the male examination, inspection, palpation, and transillumination will be used. Transillumination is used for any mass found. The patient may be lying or standing for this examination. First, inspect the genitalia for hair distribution, noting if the distribution continues around the scrotum to the anal orifice. Next, you will examine the penis, taking note of the dorsal vein that should be apparent on inspection. If the patient is uncircumcised, pull the foreskin back or ask the patient to pull it back. It should retract easily and some smegma might be noted. Examine the urethral meatus by pressing the glands between your thumb and finger. Next, palpate the penile shaft for tenderness and induration. Strip the urethra for any discharge. Next, you will inspect the scrotum. Always examine for hernias by asking the patient to stand and then asking him to bear down as if having a bowel movement. During straining, inspect the area of the inguinal canal and the fossa ovalis. You will then palpate the testes with the thumb and first two fingers. The testes will be sensitive to gentle compression, but should not be tender. They should feel smooth and free of nodules. Last, you will test the cremasteric reflex by stroking the inner thigh with a blunt instrument. The testicles and scrotum should rise on the stroked side. References: Seidel's Guide to Physical Examination, 8th edition, 2015, by Ball, Daines, Flynn, Solomon, and Stewart, St. Louis, Missouri, Elsevier.